Okay, so our next speaker is Sara Dick. Sara is a master's level CCRP, is an instructor of the health sciences research, a certified clinical research coordinator, and the most senior coordinator at the Knowledge and Evaluation Research Kerr Unit. Is this out of date, or is that current?
As of May, yeah.
Yes, that's it. I knew she took a new job. See, we just talked about that. So she has more than 11 years of experience conducting multi-center trials of patient-centered interventions, specifically in the areas of shared decision-making, minimally disruptive medicine, implementation and dissemination, and the integration of community health programs with healthcare. Most recently, she is a leading advocate of adhering to minimally disruptive research in these contents. Please welcome Sara Dick.
Good morning. My name is Sara Dick, and this presentation was established and grounded in my 11 years of experience as a certified clinical research coordinator in the Knowledge and Evaluation Research Unit. I'll be reflecting on my experiences conducting minimal risk, principal, or investigator-initiated studies. And a lot of the experience comes from doing multi-site research and going to these sites that have never conducted research before and kind of reducing that anxiety, having that research footprint kind of embedded into clinical care activities, but having a soft footprint. So how can we collect the research data that we need, but kind of collect it as close to real world as possible? So as I kind of summarized on the first slide there, the types of studies that I'll be reflecting on have a little bit more flexibility to incorporate concepts of MDR or minimally disruptive research than many of you might experience, because we reject funding from corporate sources and we have no FDA or sponsor oversight. So as I'm going through these slides, I challenge you to reflect on ways that you might be able to embed or consider concepts of MDR into the research you do. And there will be time at the end to reflect and discuss together so that we can all help each other and increase the excitement about research for participants, improve efficiencies. So let's get started. So let's take a look at Jill. Jill is a 36-year-old female who has diabetes and has an appointment on Wednesday to see her endocrinologist. She receives a phone call from an unknown study staff asking her to present early because she's eligible to participate in a research study. Jill is concerned. Who is this person? How do they know that I have an appointment coming up? But she agrees to present early to consent for the research study. And because she has to present early, she has to take extra PTO from work. She parks on the street at a meter instead of weaving around the parking ramp. She arrives at her appointment, and the study coordinator calls her back into the room to go over the consent. Because Jill was running late, she forgot her glasses. She's distracted. She's wondering what her lab values are and looking forward to talk to her clinician. She's confused as the study coordinator is going over the 15, 20 pages plus of consent. But yet she feels coerced to participate because she doesn't want to let her clinician down. The clinician enters the room now because of this consent research process behind schedule. The clinician's in a rush. And Jill begins to internally question every aspect of her appointment. Was it for research, or was it actually part of her scheduled clinical appointment? Her lab values, her A1C, are out of range today, so the clinician prescribes another medication. Jill was never able to bring up during this encounter that her lab values might be a little bit out of range because she started a new job. She's become a caretaker for her sick mother. And now the study coordinator, after the appointment, comes back into the room, administers a 20-minute survey, and this is her 5th survey for healthcare this month. Jill is stressed. She's worried about getting a parking ticket. She's also concerned, as you can see, distracted, confused, coerced. She's frustrated because of all of this and goes home and shares that frustration with her husband, which leads to her withdrawing from the study, and the post-visit phone call becomes lost to follow-up. What's wrong with this scenario? It's too much. Research is work. Research is work for caregivers, clinicians, patients, clinical staff. So how can we collect the research data with imposing a small footprint in clinical care activities? So MDRs, use MDR to manage your scope, to balance roles, improve excitement about research. So again, we're collecting research data with the smallest possible footprint on clinical care activities to result in careful and kind research. So patients live complicated lives. They have to balance the roles between taking care of themselves, kind of the tasks that healthcare places on them to take care of their chronic diseases or what it might be, but then also the roles of being an employee, a volunteer, a spouse, a parent. So how can we reduce the work for them? By a show of hands, how many have participated in conducted research where you've asked the participant to come back for multiple clinical visits? Okay, this can be multiple times in a week, maybe expanded over a month. Maybe they're coming back multiple times throughout the years, for many years. It's a default to ask for the moon. Again, I ask, how many of you have experience participating in surveys or administering surveys as part of your research work? Okay. So you might be able to reflect on your experiences of, you're going to ask these research questions at this research time point, and since we're doing that, let's just ask these research questions as well. Or maybe another investigator finds that you're administering a survey, and they add their research questions to your research study as well. Now the survey is between 30 minutes, maybe an hour in length, and it's out of scope. So minimally disruptive research, considerations for the patient participants. Can a patient be approached at a single pre-scheduled visit? Can we utilize wait time efficiently? Collect usable data. So again, going back to the surveys, what do we gain as researchers in collecting data that's not going to be used? We gain nothing. Conduct videographic analysis. I have extensive experience with my research team using a GoPro or a flip camera. It's about the size of a deck of cards that we set on the exam table, looking in at the conversation between the patient and the clinician. And it's just one way that we can minimize that research footprint, be as invisible as possible. And what we find is that the camera just kind of becomes lost in the clinical encounter. It's not a distraction. And engaging stakeholders, patients as stakeholders through every step of the way. So taking a look here on the next slide, okay, can they be approached at an already scheduled clinical appointment? So taking away that pre-contact. Can we capture their consent and their data at a single time point? Can we capture their consent during that downtime when they're waiting, they're roomed and now they're waiting for their clinician? So that's downtime. Can it be turned into valuable time? And eliminate that post-follow-up visit. Can you administer surveys at that clinical appointment? Okay, if you're capturing it right there, reducing that extensive participation. We'll be talking about how it may increase excitement, okay, and then reduce the data that's lost to follow-up, but then also you're collecting meaningful data. I'm sure many of you have experienced as you're entering data from the surveys and a patient just drew a line all the way straight down the page, ones the whole way down. So if we minimize that, can we collect more meaningful data? An investigator has shared with me that when they're using surveys or looking at what data to collect, they think about what data they're going to publish, and they use that, and they only administer those questions. So it's making sure that you're collecting usable data. Also, can you use just part of the validated tool, part of the validated survey, instead of using the whole scale. Think about that videographic analysis again. Can you collect the data by recording it? This data can also be analyzed at a future follow-up time by research staff. Can you collect data through the videographic analysis and take out some of the questions, and you no longer have to ask them in your survey? Think about the body language that you can study, different qualitative results you can get from videographic analysis. What questions are being asked during the clinical encounters? Who's asking them? At what time point of the clinical encounter are they being asked? Are concerns being addressed? Is it side effects of a medication or the cost of the medication? Videographic analysis is a powerful tool. Implementing MDR adds value to the research, minimizes the work for the patient. Research subjects become participants. There's a sense of amplified empathy, effective use of that scheduled time, making it valuable time. Increased capacity for patients as they're managing the roles of being patients, research participants, and the other roles we discussed outside of the healthcare setting. Escalate excitement. They excited to continue the participation throughout your whole study? Are they excited to participate in future research studies? Reduce the loss to follow-up data, stronger completion rates for more meaningful data. Also looking at clinicians then. Clinicians live complex lives. They're asked to see more patients in tighter schedules, in reduced time slots. And now we're asking them to do research on top of it. Often, clinicians are asked to identify patients, review inclusion and exclusion criteria, and also consent patients. So let's consider, can we utilize roles effectively? If we take away the administrative role, the research role of clinicians, they themselves, clinicians, can be research subjects. We can further understand the delivery of care. Clinicians can still be engaged in research. Use clinician champions. And again, engage clinicians as stakeholders, as the experts of clinical care, of data, policy, guidelines. So looking here, can study coordinators or other trained research staff identify the patients? Okay, reducing the research work for clinicians. Train them to review the inclusion and exclusion criteria, but again, clinicians can still be involved in the research process. Use them as clinician champions. They can just confirm eligibility. And then if we take that administrative role away from clinicians and consent the patient, we can also consent clinicians, especially if you're doing the videographic analysis, to be subjects themselves. So it adds value. It reduces the research burden on clinicians and minimizes that footprint in their clinical care activities. So think about delegating work to the appropriate person. As clinical research coordinators, we have extensive experience in human subjects protection. Let's be the ones consenting the patients and approaching the patients, reducing that coercion where the patient feels that they have to participate so that they don't let their clinician down. But human subjects protection also goes beyond what we think of as human subject protection training. It also goes back to the first couple slides about patient capacity. So incorporate that. It increases capacity for their clinicians to establish relationships with their coworkers. Can they get their colleagues excited about participating in their research studies? Excited about participating in other research studies? Can it improve the delivery of clinical care if we reduce some of their demands? Can they take the time, this extra time that we've created, to establish that trust, build on that relationship with their patients? But how do we really know? How do we understand what is burden? This adherence, or adhering to minimally disruptive medicine, incorporates engaging stakeholders at every step of the way. The top slide is a patient advisory group that we've used for over 11 years. I've used them to practice presentations. We've used them to practice consenting, okay? Especially if we kind of get in this rut where maybe we've had a few declines of patients choosing not to participate in our research. We go back and reflect. Have we gotten that monotone, that consistent consenting down versus making sure that we're engaging on that relationship and making sure the participants fully understand what we're asking of them. Administer surveys with the patients as well, or you can see that in the bottom picture there. This is at a community event where we're doing linking kind of community resources, embedding them into healthcare. Okay, so we're practicing the surveys here. Are they receiving the questions the way that the questions were intended or developed? Did it take 10 minutes like we thought it would, or is it taking 40 minutes? Was that 10 minutes a breeze, or was it a struggle? Okay? Patients, clinicians, caregivers, clinical staff, they are the experts. Engage them at every step of the way. Conduct participatory research. We're not going to get it right on the first try. Stay engaged throughout the entire process and adapt. So minimally disruptive research. How can we impose the smallest possible footprint on clinical care activities? It's no one size fits all. Depends on your research department, your research processes and methods, your research group. Find the method that fits your oversight and funding and adapt. Challenge traditions. Push back. It might take more time initially to engage stakeholders. Make sure we're collecting useful, meaningful data. Assigning roles efficiently. Yet the outcome is to create more secret sauce. Time. Time for all involved. So let's take a look back at Jill. So before concepts of MDR, can we turn those feelings of frustration, anxiety around and have feelings of excitement, energy, empathy? Participating in research can be a huge sacrifice. Let's appreciate the work that our participants, their time, their competing priorities and demands. So now I'd like to take the time to open it up to you. I'd like to share on our reflections, maybe different areas where we can embed concepts of MDR. If you have questions for me, I can reflect a little bit more on my experiences, maybe research studies we've done where we've done the pre-phone calls or we've contacted them directly prior to their scheduled clinical appointments. But right now, it's about you and how I can help and how we can help each other. All
right, so just raise your hand and Eric will bring you a microphone. Up here. Oh, this is good. Somebody up here and then somebody way back there, okay, please? That'd be perfect, right? Raise your hand again, just so in case Eric didn't see it. There you go. Thank you.
Hold it up close.
Hi, good morning. Thank you for your presentation. I know that you mentioned earlier about the video graphics that is within the clinical exam room. I was just wondering if is that in your practice, or are you just suggesting that we use that?
Yep, so we have extensive experience in the research studies that we do. We are primarily kind of housed under endocrinology, so a lot of like chronic disease studies, minimal risk studies that we do, but we also have done videographic analysis and video recorded in the emergency department, primary medicine, internal medicine, kind of the family, but then also other areas as well, CV research, But we do it, and I myself, as a coordinator, when I bring in the camera, I bring it in when I consent, and I show the participants that this is what I want to video record with. It's not going to be this big, extensive machine, multiple people that I, come in the room with the clinician, but it's just this little camera that we're going to set on the exam table. So it's just kind of how can we reduce that anxiety and make it a comfortable experience for the participants. And then we also share that it can be turned off at any time by anyone, so the clinicians, the patients. Something that I'm really surprised about, kind of in the social media era that we're in, is how many actually do participate with the video recording. When we initially started it, like I said, over 11 years ago, we thought that maybe we'd see an increased decline rate, and that's not the case, and it's continuing to be the same, is that patients are still eager to participate. And with the videographic analysis, like I said, we're able to do qualitative research. Are we seeing that the computer screen is being more hindering the appointments because the clinician's looking at that while the patient's looking out the window behind the clinician? And then we test decision aids as well as the research that we're doing, so kind of discussion tools. And so then we look at, okay, time or the clinical appointments without the discussion aid. What does the body language look like? What are the concerns, questions that are being addressed? And now we're doing, we're implementing the decision aid, and it changed the body language, it changed the questions and concerns, it focused the discussion. So there's so much that we've been able to capture with the videographic analysis.
So do you guys have a separate informed consent for that? And is this against breaching patient confidentiality?
Yeah, so we have in our research consent that I choose to be videotaped or recorded. There are a couple that choose only the audio recording, so we just turn the cameras down or up towards the ceiling so it doesn't capture the picture part. But we do have it in our consent form right now, and just like any other research data, only those that are approved by our IRB on our research protocols are allowed to see those videos. So does that answer your question? And then we, at Mayo Clinic, we also do have extra authorization forms to include, or to have the patient and sign saying that it's okay that they're videographed.
Thank you for a great presentation. My question has to do more with, you're talking about trying to decrease the visits before and after the one where you're actually completing the study activities. Mm-hmm. And so I know a question that I often have is, am I still providing my participant an ample amount of time to make a decision? And so how do you find that balance between not doing more than you have to and increasing burden, but still finding an ample amount of time to allow your participants to make a decision?
Thank you, yes. That's one consideration too, where if you're not contacting the participants ahead of time, are you giving them that ample time, to make the decision? And I think as trained research staff, trained research professionals, there's things we can do, look at their body language. Are they saying yes because they feel coerced, that they're not really understanding? And with embedding this research and these concepts into a lot of chronic care disease where they're coming in for a follow-up appointment, maybe once every 6 months, maybe once every year. Are we gonna, if the patient declines at this time or wants more time to think about participating, is our research study gonna be close to enrollment at their next, scheduled follow-up? But I think that just goes back to putting the patient first or the participant first. There are times where maybe they did have enough time, enough information choose to participate in the study, and that's great. And then, like I said, there's other areas where we just need, as trained research professionals, be able to look at the bigger picture, read the body language, excuse ourselves, if there's not enough time or if the patient has a lot of questions. We've had experience just saying, today's not the best day to participate. We thank you for your time, but just kind of having those tools in your toolbox. How can you excuse yourself? But then maybe if it's just there isn't enough time, the patient wants more time to participate, just letting them know that we appreciate their time, we appreciate their consideration, and they want to take more time. We have to have their consent prior to them participating, so maybe that will help them understand the big picture, or maybe that's just kind of the closure that the patient needs, is that it's just not best for me right now, and MDR might not be applicable in that research time or that research process, depending how it's set up. So thank you.
I had a question about billing. So how do you
bill for the time? So if you have a clinician involved in the visit, or if you're doing other study procedures, how do you separate out the billing between what's clinic related and what's research related?
So with the research related, are you asking about like the consent processes, survey administration, maybe examples like that?
Well, you had talked about, instead of having a separate part of the visit or a separate visit that's the research part, doing it all incorporated with the clinic visit. So when you do that, how do you separate out what is being billed for time-wise for the clinic, and then what's part of the research visit?
Yep. So a lot of this presentation was based on investigator-initiated studies, minimal risk studies. So they are coming for their chronic care visit, maybe only one scheduled visit in a certain annual time frame. And so FTE is how we bill a lot for the research processes, like the waiting time, the consenting time, administering the surveys, things like that. But the patients are coming for their pre-scheduled, their chronic care visits. And so that is billed to the clinical components, not the research components. So like Tammy mentioned now, I currently have a new position as a pre-award specialist, a research protocol specialist, and so I'm learning more and able to take my experience from 11 years of minimal risk studies and how can we embed them into drug and device studies where there really is strict guidelines on what can be billed and that. So to kind of answer your question or summarize, most of the research process was billed as FTEs to the study coordinator, and I'm gaining more experience now and open to your ideas how MDR can be embedded in separating the billing.
I don't really have a question, but I would like to share an observation, and it may help some other people. We were having extreme difficulties consenting patients for our registry. The nurses are like, you can't stay in this room this long, because we do them at the consult visit, and we'd always gone down after the consult visit for a few minutes and talked with them. And I just couldn't figure out how to turn this into lemonade. And I got to thinking, and I realized, we should be doing a better job of consenting our patients anyway when they become subjects. So I came up with a plan, and it's worked well for us. So at the end of the consult visit, we do what we consider a meet and greet, and we meet the patient, we introduce ourselves. The PI has already mentioned the study before we go in, and we talk to them briefly about, this is the study, this is what it entails, this is what will be expected of you. This is an invitation. We would love for you to participate, but you may tell us no, and if you tell us no, your care is not going to change. If you tell us yes, your care is not going to change. But we would like to see you when you come back for your preoperative education appointment. Please take the consent form home. It is your copy. Mark on it, write on it, do not sign it. When you come back, we'll discuss it again. Well, they come back for a preoperative education appointment by our nurse, and at the end of her visit, she calls us down, and we come and we visit for 10 or 15 minutes. And do you have any questions? Did you read this? That's the first thing. Did you read this? And that way they've had adequate time to the opportunity. Now, whether they take it home and throw it in the trash or lay it on the bedside table, we don't know, but we have done our part. And therefore, we're able to consent them before anything happens, before any study activities happen. They consent. We send them on their merry way. We go back to our offices. We make copies of the consent form because we keep the original. We mail them their copy with a letter thanking them and reminding them again that at any time they are free to withdraw. And it's worked well for us. I know all practices are different, but if you have that many scheduled visits in your practice and they're going to come back, it certainly has alleviated stress on the patient, in the clinic, and on our research staff. So hopefully it will help someone else to do this. It's a very good suggestion. Thank you.
Thank you.
For sharing it. Sorry.
No, thank you for sharing that. And it also reminded me of one part, too, where I was talking about engaging stakeholders, patients, clinicians, but also I hope many of you as research coordinators, pre-award specialists are engaged in the grant writing as well, if that's applicable to your work, because you are a stakeholder. How can we be engaged at the forefront, so when we're running into what does it look like to consent, what clinical areas, are we might be holding up, or what clinical areas do we need to use as resources? Can we have those those discussions right away at the beginning, engaging participants, stakeholders, study staff. It strengthens grants, strengthens reports. So thank you for sharing that.
Thank you, Sarah.
Thank you. Thank you.